So welcome everyone. My name is Manon. Welcome to the second global test of the year. I'm working in the Global Training and Product Support Department at CellaVision in Lund, and we organize global tests 4 times a year. So this is the second one. And before I introduce the speaker for today, I will go through some housekeeping information. And first of all, we ask you to mute your microphones so it's easier for us to speak without disturbances. And if you have any questions, please ask your questions in the chat or raise your hands. We prefer that you ask questions in the chat, and we will try to answer these questions either during the presentation, but most likely at the end of the presentation. This webinar is recorded, and we will edit the recording at the end of the session. So no name or no personal information will appear on the final recording that we will publish on the website, and we will also send you the recording by email. So you will get a copy of it and you can share it with your family, your friends, your colleagues, and your students. And you can rewatch it at any time. So at the end of the session, we hope we can send you the recording by the end of the week, but most likely you will receive it within 2 weeks due to some vacation with our team. And in the email you will receive, you will get the recording and also a certificate of attendance for those who need some. And our speaker for today is Dr. Abdul Ghani Alatar. Dr. Abdul Ghani Alatar has a master's degree in clinical experimental laboratory medicine and also a PhD in medical science in the field of hematology and transfusion medicine. Dr. Alatar is the author of numerous abstracts, posters, peer-reviewed publications in the field of hematology and transfusion medicine. And he is also a CellaVision academic consultant. And here in the presentation, you can see his thesis, and we will send you a link to the thesis together with the recording after the end of the webinar. So in the email, we will send you with everything. So we are very happy to have him present today. And Dr. Abdul Ghani Alatar, whenever you're ready, you can start sharing your screen.
Thank you, Manon, for the nice introduction. So first of all, I would like to welcome you all for joining us today. And also I would like to thank you for taking the time to complete the test. It was really enjoyable to go through your answers and comments, which we have used actually to develop the key aspects of this webinar. So now let's take a few minutes to go over some highlights together. But before we proceed, I would like to briefly clarify a few important points regarding the protocol and images used in this presentation. First of all, it is important to recognize that the protocol discussed here may differ from those followed in your laboratories. Please take into account that laboratory practice can vary by institution, equipment, accreditation guidelines. Therefore, you should always follow your laboratory established policies and guidelines when performing diagnoses or interpreting results. Secondly, the examiner results referred in this presentation reflect the interpretation of experienced morphologists at CellaVision. Our colleagues bring a significant expertise in digital hematology and morphology reviews, which helped support the case evaluation and image assessment that will be discussed today. Where we will walk you through an diagnostic exercise focusing on white blood cell differential, red blood cell morphology, and the interpretation of the results and observations. So we will start with a case presentation where we introduce the clinical aspect of patients and the patient's finding in general, which include a detailed review of white blood cell differential, red blood cell morphology as assessed by CellaVision DC-1 system. Next, we will move into the results overview, where we will examine the key findings from the case, and then compare these results align or differ from the classification made by you and compared to the examiner. We will also be discussing common area of discrepancy and why these differences matter in clinical diagnosis and standardization effort. Then we will shift our focus to the disease at the center of this case, which is Lyme disease. In that section, we will cover what is Lyme disease and what is the sign, symptom, how to accurately diagnose the disease, and how it fits into the World Health Organization most recent guideline. By the end of this session, we aim to provide you with a deeper understanding of specific cell type involved in this case and how the combination of automated analysis tool, morphological expertise, and updated guideline contribute to the accuracy of diagnosis of Lyme disease. Let's start with our case today. Today we present the case of a 28-year-old woman who arrived with approximately 10 days history of flu-like symptoms. These include fever, fatigue, and generalized joint pain. The primary concern was swelling and pain localized to the right knee. The patient noted this developed alongside the systemic symptoms. In addition to that, the patient reported a recent sport-related injury to the same knee, which initially suggested a mechanical cause. However, the persistence of the systemic sign raised quite concern for an inflammatory or infection. Due to the symptoms, the patient was referred to the emergency department for an urgent evaluation and diagnostic investigation. The initial blood work was performed as part of diagnostic assessment. The white blood cell count was mildly elevated. This leukocytosis suggests a possible inflammatory or infection process, consistent with her systemic symptoms, while hemoglobin were indicating mild leukemia, which this could reflect a chronic inflammatory response or possibly early bone marrow involvement in this systemic infection. The red blood cell count was slightly below normal. This suggests the anemia finding likely of the inflammatory or non-hemorrhagic origin given the clinical context of it. The platelet count was borderline low, while not severely thrombocytopenic, and this could indicate immune activation due to early bone marrow suppression or a process related to infection or inflammation. So let's start with the examiner classification. The differential white cell count gives us further insight into the immune response, as we can see here. These findings demonstrate a marked neutrophil predominance with relative lymphopenia. The elevated proportion of the band and segmented neutrophil indicate a left shift commonly seen in acute bacterial infection or systemic inflammation. The band neutrophil are immature form of the cell, suggesting the bone marrow responding actively to the demand, while total neutrophil band and segmented exceeded 86%, reinforcing suspicion of ongoing infection process. Together with the clinical presentation, this finding raised strong suspicion of an infection, monoarthritis, with Lyme disease remaining high on the differential. Moving to the white blood cell examination, the smear revealed the presence of normocytic, normochromatic red blood cell, which indicate that the anemia is not due to iron or B12 or folate deficiency. Anicytosis, a variation in red blood cell size, suggesting a mildly regenerative or reactive process. And the occasional microcytes may point to early changes or mixed anemia. So these findings align with chronic inflammatory state rather than a primary hematologic disorder. Critically, spirochetes were observed on the peripheral smear. This is rare but highly significant finding and strongly support a systemic spirochete infection such as Borrelia, which is the cause agent of Lyme disease. Other differential consideration could include relapsing fever, Borrelia, though less likely in this clinical context. So let's move on now to your results. So overall, there was a good level of agreement between your classifications and the examiner's classification, both in terms of white blood cells, differential, and red blood cell morphology. This is really encouraging. Now let's take a look at a couple of cells that showed a larger degree of disagreement among reviewers. Here is the first cells, and here we have the second one. Even more varied in classification, actually, looking at the number here. In both cases, the examiner classified these cells as monocytes. However, the second cell in particular received a broad range of alternative classifications from multiple users. This kind of variation highlight the challenges in morphological identification, especially with isolated images. So, but here where the strength of digital cell morphology comes in, where we view these cells in the context of their neighboring cell. We can better appreciate the shared feature. So, looking at them like this allow us to clearly see the monocyte is indeed the correct classification for both. So this grouped cells perspective enhances accuracy and confidence in your classification, especially when dealing with borderline or atypical morphology. Always try to use this feature whenever possible. You simply make better, more confident decisions and reduce classification variability. Another frequent source of disagreement in cell classification comes from how we handle smudged cell or partial cells. This variability is well known and often depend on lab-specific practice, so it's not surprising to see inconsistency across different users here. Some classification resources suggest that if a cell appears damaged or squashed, but you still can identify its lineage, you should go ahead and classify it by its apparent cell type, rather than just marking it as a smudge. This guides line helps retain diagnostic value even from imperfect cells. Here the examiner labeled both of these cells as smudged. However, many users identified the left cell as a smudged neutrophil, which is also a reasonable and justifiable classification. This highlights how interpretive judgment can differ even when visual information is the same. What is important here is to acknowledge this gray zone. While there is often no absolute right or wrong, your choice should be consistent with your lab guideline practice and the purpose of your review. In teaching or research setting, we might want to note both impressions, but in clinical practice, being methodological and transparent is how we treat borderline cells is essential. So in summary, smudged cells are a non-source of disagreement. If lineage can be confidently determined, it is acceptable and sometimes preferred to classify based on cell type. And of course, lab policy and consistency are key to how these decisions are made. So even if your source even if your score in the test looks low, you should take into account which cell were marked wrong. Were they really wrong? In this example here, our colleague at CellaVision, Emily, can see that she differ based on the classification of smudge versus artifact. So take a close look at what exactly was marked wrong and compare to the examiner. This is really just, and in this case, this is really just of a difference between smudge or artifact. Another example here, you can see that while she has some wrong, this is really just a definition of band versus segment neutrophil. So even if your overall score looks low, it is important to look deeper at the details and really ask yourself which cell were marked wrong, and more importantly, were they truly wrong, and was it a borderline cell? So remember, look at which cell were flagged, reflect on the reason for the mismatch, and recognize that some variation is expected and even healthy in morphological interpretations. So this is moving to the white blood cells, red blood cells. So this one was a little bit hard, and the result showed it. Almost 2/3 of participants who took the test graded this case as 0 for parasites, while the rest ranged from 1 plus to 3 plus. So this kind of variation might seem surprisingly at first, but it actually makes sense. Technically speaking, spirochetes are a distinct type of bacteria, not classical parasites. However, many spirochetes behave like parasites. They live off a host, derive nutrients from that host, and often cause disease in the process. So depending on how your lab defines parasites for scoring, different responses may be equally valid. That's why in this case, whether you graded the parasite 0, 1, 2, 3 plus isn't what truly matter. What's important that you saw the spirochetes, you recognize their significance, and you reported them according to your lab policies. That's a good morphological awareness and good laboratory practice. What's matter is that you saw what was there, understood the clinical impact, and reported it clearly for follow-up. One of the main also area of disagreement in this review was clearly the neutrophil populations. Understanding the subtle differences between band neutrophil, segmented neutrophil, and toxic is critical for accurate classification. So here let's break this feature down. The nuclear shape of band have a curved or board-like nucleus, sometimes S, C, or U-shaped, with visible chromatin connections. While segmented neutrophil have 2 to 3 distinct loops, and toxic neutrophil can show both band and segmented form, but often with toxic changes. While chromatin in band neutrophil have gross and clumpy chromatin, whereas segmented have a toxic neutrophil have clumped chromatins. And the cytoplasm of band neutrophil typically have pink cytoplasm, rich in specific granulo. Segmented neutrophil have a paler cytoplasm with fine granulo, and toxic neutrophil have basophilic cytoplasm with dark granulus and voculus, indicating toxic changes. The band neutrophil tend to be larger than the segmented and the toxic. The band is around 10 to 18 micromolar, and while the segmented and the toxic neutrophil usually range between 10 to 15 micromolar. Here I included a little bit more information how to define them if needed. I will not go over all this, but you will get it later on when we send out the handout for the presentations. So when classifying neutrophil, pay close attention to nuclear shape and segmentation, observe the chromatin pattern carefully, and look at the cytoplasmic changes that indicate toxicity. Consider cell size in relation to the populations. We'll start with talking about neutrophil. So we'll start by Neutrophil, as you know, are the most abundant white blood cell in the human body, playing a crucial role in our immune defense. They develop in the bone marrow from hematopoietic stem cells, and here is just an illustration to the left. You can see how the hierarchical process of the development, where it goes through a series of intermediate progenitor cells before maturing and entering bloodstream. So starting with the multipotent progenitor, which called MPP3 here, as highlighted in the figure, these cells slowly commit to myeloid lineage. This is the first step toward neutrophil maturation. MPP3 cells can either proliferate or differentiate into granulocyte monocyte progenitors. These GMPs often cluster together in loose patches within the bone marrow, facilitate further development. The GMP cluster then they differentiate into pro-myelocyte and myelocyte, which continue to form cluster in the bone marrow. As this progenitor cell mature, they gradually lose their ability to proliferate, and a process regulated by transcription factor, which an intrinsic factor, called in this lineage CEPPE. From there, the cells mature through metallomyelocytes and band cells, as highlighted here, eventually becoming fully mature neutrophil ready to enter the circulation. So under normal hemostatic condition, neutrophil population in the bone marrow is divided into two main compartments. The mitotic pool, which consists of dividing progenitor, specifically promyelocyte and myelocyte. These cells are actively proliferating. And the second is a post-mitotic pool, which contain maturing but non-dividing progenitors, including metamyelocytes, banded cells, mature neutrophil, and hypersegmented neutrophil. The time it takes for neutrophil to progress through the post-mitotic pool from immature to fully mature cell ready to enter the circulation is approximately 5 to 6 days in human. The exact origin of different functional neutrophil phenotype remain unclear. They may arise from signal or instruction received from tissues, like extrinsic signals, parallel differentiation pathway, or even transdifferentiation process, where cells change their identity. What's their function? So they have several critical functions in the immune system, which can be summarized as follows. I listed them briefly here. So while neutrophils are essential for fighting infection, their powerful antimicrobial action can sometimes cause collateral damage to the host, playing a role in autoimmune conditions. This dual nature makes them both vital defender and potential therapeutic targets. Neutrophils plays a crucial role in defending the body through three main antimicrobial functions. On this slide, we highlight both the positive aspects of these functions, which help protect us from infection, shown in green in the figure here, and the negative aspect, which can sometimes harm the host, shown here in the red to the right in the figure. The key antimicrobial functions include phagocytosis, engulfing and destroying pathogens, degranulation, which releasing toxic enzyme and chemical to kill microbes, and formation of neutrophil extracellular trap nets, which are a web of DNA that trap and neutralize the pathogen. To connect the dots, let's review an important aspect of Lyme disease, including its cause, transmission, symptom, and risk. Understanding this point is critical for early diagnosis and effective treatment of Lyme disease, which can otherwise affect multiple systems in the body. So, now let's look at the sign and symptom of Lyme disease across different stages. Let's review the sign and symptom of Lyme disease at different stages. So in early stages, patients often develop erythema migrans, as you can see here in the figure to the left, which is an expanding round or oval rash frequently showing a bull's-eye pattern. Other common symptoms include fatigue, chill, fever, headache, muscle and joint pain, and swollen lymph node. This rash typically appears between 3 and 30 days after tick bite and occurs in about 70% of cases. It is usually not itchy or painful. It is important to distinguish this from allergic reaction of tick bite, which appear earlier, and disappear within few days. While the late severe Lyme disease, patient usually and may experience arthritis with severe joint swelling, often affecting the knee. Neurological symptoms also such as numbness, facial paralysis, and meningitis can also occur, as you can see here in the figure to the right. Heart rhythm irregularities are rare, but also been documented in late or severe Lyme disease. After the treatment, in general, a small percentage of people may continue to experience fatigue, body ache, or difficulties with thinking, even though the infection has been cleared out. So early recognition and treatment are key to preventing these serious complications. Now, let's discuss key observation and diagnostic pathway for Lyme disease. One important observation is really the presence of spirochetes, specifically Borrelia bacteria, which can occasionally be seen in blood smear during early bacteremia. If spirochetes are observed in the smear, this is a really critical finding that require immediate further testing to confirm the specific type of infection, whether it is Lyme disease or another spirochetal infection like relapsing fever, Borrelia. So always use the FDA cleared antibody test. Antibodies may take several weeks to appear. In early stages, blood tests may be negative in the first few weeks after infection, while late stages, most patients infected more than 6 weeks will test positive. Persistent antibodies can remain in the blood for months or years post-recovery, so it's important to know. And while negative late test is someone with a long-term symptoms like arthritis, suggested Lyme disease is not a cause. And the reinfection cannot be distinguished from past infection using antibody test. So the diagnosis is really depending on clinical judgment in this case. While the treatment, the recommended is antibiotic include doxycycline and amoxicillin. The main goal of early treatment is really to prevent progression to more severe form of the disease, such as neurological, cardiac, or joint complications. To conclude, and coming back to our case, where an adult female presented with a fever, fatigue, joint pain, and swelling of the right knee. Peripheral blood smear revealed normocytic, normochromat anemia, anisotosis, occasional microcytes, and importantly, visible spirochetes, confirming a spiritual bloodstream infection. These findings basically are consistent with Lyme disease with the monoarthritis, suggesting possible Lyme arthritis. Also, early signs like erythema migraine are absent. The presence of spirochetes and clinical symptoms required us to take further actions and an immediate action. So it's important to follow this up with FDA-cleared serologic testings to confirm Borrelia infection, followed by targeted antibiotic therapy to prevent disease progression. And in many cases, before when suspicion is made, usually prophylaxis are given to patient. Here, blood smear shows yes, here's just to show you an image of spirochetes. And finally, I would like to conclude with highlighting some good reading on neutrophil development and their role in Borrelia and in general infection. And I would strongly recommend also going through the CDC overview of Lyme disease, which basically summarize in a light way what you really need to know about it and how to prevent it. But you can enjoy your outdoor nature walk. With that, I would like to ask Manon to go back to the questions.
Thank you very much, Dr. Abdulghani Alatar, for this presentation. We have some questions in the chat. The first question we have is, due to the variation of tech-to-tech review, is quantifying bands versus segmented neutrophils still a recommended practice, especially now that there are some analyzers that can provide the immature granulocyte parameter? Can you help answering this question?
Well, that's interesting questions. I would really refer you to really the guideline of your laboratory in this case, and until the standardizations really more defined in the future. So
I would maybe add, if I can, it really depends also on where you are in the world. So you're right, there are more and more advanced analyzers that can provide these those parameters, but there are also, you know, large areas of the world where they don't have that advanced capability. So we really see a wide variation on policies regarding bands. I think that the trend is to not separate them from the segmented neutrophils. That's certainly the trend that we tend to see around the world in more advanced healthcare. We also, though, do still see in certain subpopulations, like children's hospitals, for example, where the policy is that they only identify or separate bands when they are greater than a certain percentage. So that's also a trend that we see. But yeah, fewer and fewer institutions with you know, high-end equipment are separating the bands from the neutrophils. I would say that we do see that, but as Dr. Alatar said, ultimately it's up to whatever the medical director in that laboratory decides. But it's trending that way.
Thank you. Is there any other question before we move on? So this is the end of our webinar. We are thanking you all for joining us today and wish you a very nice day. And please keep an eye out for the next global test in the fall.